Thanks so much. Thank you, everybody from across Turtle Island for coming today. So we're talking about SARS. Oh, first a sound check. Can you hear me properly? Great. So we're talking about SARS-CoV or COVID-19 induced chronic disease in primary care. Dr. Angela Grace, psychologist here in Calgary, will be joining us. She's here and she'll be helping with a patient perspective on this topic. So welcome. Here's my disclosure. Basically, I don't make any money off of COVID or COVID precautions in any way, shape, or form. Though I think if somebody's looking for investment opportunities, I think things to do with indoor air quality, that's going to be an industry that will have massive expansion, but I'm not personally investing in it, so I can stay free of conflicts of interest. I've listed here under my other sort of affiliations and so on, in case somebody perceives that these could be potentially a conflict of interest, but they're really just, I'm an academic family doctor, and this is sort of describing it. I'd like to specifically acknowledge Dr. Angela Grace, Dr. Gazia Gasperowicz, Dr. Shelley Ungren, Dr. Mark Ungren, and Dr. Joe Vipond, who have helped with pointing me in the direction of certain things when I was either looking for trying to understand key sources of data or understand key themes. They've helped in various ways with today's presentation. So some quick terminology. COVID-19 is the term that the WHO has assigned to the condition caused by the current coronavirus that's circulating. It's often also referred to as SARS-2 or SARS-CoV-2. Those are basically interchangeable terms largely. You'll hear or see in the titles of some of the papers that I show and to describe some of these terms being used. In general, the SARS-2 or SARS-CoV-2 is probably actually a better term because we know the original SARS or SARS-1 was a virus that caused not just severe acute disease, but long coronavirus condition that was quite disabling to many people. And a recent article published described how none of the 50 people in a certain cohort improved dramatically from their long coronavirus condition. And we're looking at much of the same thing today. The objectives: by the end of this session, you'll be able to describe the massive increase in complex chronic disease caused by the ongoing SARS-CoV-2 pandemic, identify steps to mitigate the eventual magnitude of these oncoming waves of complex chronic disease, and explore implications of this massive increase in prevalence of chronic disease on primary care and family medicine so that we can care for patients, things to do with the system, practice, research, education, and innovation. So what a family doc does, when we're a family doctor caring for a patient, we're always alert for signals or signs that suggest a health risk or even a health opportunity for our patients. This is often very early and sometimes even before an official diagnostic criteria set are met. It's noticing that something's up with our patient and that maybe they're struggling with a mood issue, or there's just something about the way they describe a change in their function that isn't maybe a classic way to think about presentation of somebody with new onset cardiac disease, but our spider senses tingle. And so that's kind of what today is about, except for instead of thinking about what are the implications of these signs and signals for a patient, it's for our society. Although actually the evidence I'm sharing is really, really strong. These aren't subtle tea leaves anymore. These are well-established research data that really leaves us with the question that the only real uncertainties are around the ultimate magnitude of how bad and big the impact of long COVID will get and what we will ultimately do. So in other words, question one is, how bad and big is this? How bad and big is long COVID or long SARS-CoV-2, and what do we need to do about it? So first, how bad is it? So this is where I'm going to welcome Dr. Angela Grace to share her story. To be clear, she's not a patient of mine. We have no conflicts of interest in relation to each other, and there's no compensation has flowed in any way to facilitate her ability to be here today. She's a psychologist here in Calgary and is a sessional academic faculty member with the University of Calgary. Angela, over to you.
All right. Thanks so much, David. Okay, well, I'm going to try to explain the last 11 months of my life in the next 5 minutes. So February 6, 2022, I was snowboarding in sunshine. It was a wonderful day. I felt strong. I felt healthy. I felt good. I was at the top of my career. In January, I had just finished a 16-hour dance workshop weekend. So I was great. February 12th, I had a tickle in the back of my throat, and I thought, oh no, is this it? The next day, I felt really unwell. So I went and I was able to get a PCR test, and it did indeed confirm that I was positive for COVID. My husband got a test too, and he was positive, but he had 0 symptoms. The next day, I ended up in emergency because I could not breathe. Like I was in complete and utter distress. And the emergency doctor was fantastic. He said to me, Angela, I know you're really scared right now. He says, I'm going to try something. And if that doesn't work, then we're going to probably have to put you on a ventilator. So I was scared. I thought I was either going to be on a ventilator or die. And he gave me 1,000 milligrams of Tylenol and 600 milligrams of Advil. And 20 minutes later, I could breathe. So he said to me, this is serious inflammation. You need to do this every 8 hours for the next few days. So to keep the inflammation down. And so he sent me home 1,000 milligrams Tylenol, 600 milligrams Advil every 8 hours until I felt better. So turns out I had to do that every 7.5 hours because 7.5 hour mark, I just couldn't breathe. I then spent the next 9 days flat out on the couch. My husband helped me move from the bed to the couch. Somehow he got food down me. I don't really remember, but I do remember watching entire seasons of Game of Thrones in one day, because that's all I could do was lay there. And it was really, really scary. So I'd gone from being super healthy, hiking 20K, doing whatever I wanted, to I couldn't breathe. And then the headache started. It was a deep brain headache that nothing could touch. Like, I don't know, it really was a deep brain headache. And then the fatigue, like I literally had no energy to do anything. I'm in private practice. I don't have sick time. I don't have short-term disability. If I didn't work, there would be no mortgage paid and food on the table. So slowly I had to get back to work. So I moved my clients to Zoom, saw a couple a day, and then crashed. So it was incredibly, incredibly hard. The hardest thing was the fatigue, and then the tachycardia that happened, the deep brain headache. This is not my voice. I have a very clear voice. This is really congested. It's been this way for the last 11 months. I'm also a singer. I have no lung capacity to sing. So I ended up in emergency 2 more times because the one time I couldn't breathe and the other time I thought I was having a heart attack. So in going back to my family doctor after a few months, I know her frustration as well, because she'd be like, okay, well, let's send you for some more tests. And all the tests are positive. All the tests show my lung function is fine. My heart functioning is fine. The neurologist was great. He's sending me for an MRI, but of course it's a 9-10 month wait for that. So I don't know what's going on. I was telling my friend about this deep brain headache, and her son was diagnosed with migraines, and they gave him this little tiny device called a cephaly. And I was so desperate, I tried it, and it worked. For the first time, I felt like I had peripheral vision. My brain fog was gone for a day, and I didn't have a headache for a day. So I invested in the device, and I use it I had to use it this morning, getting out of bed. So then, of course, the depression hit, and my doctor observed, she's like, this isn't you, Angela. And I'm like, well, of course it's not me, because I can't live my life. So then it's determining, is it a biological depression that an antidepressant would help, or is it true inflammation? And I'm on the side of it's inflammation. So I didn't take the antidepressant because I'm working on reducing the inflammation. So I am on the mend because my energy is improving, but I know people that are not. One of my best friends, Paul, he's written a book about his 39 days in a coma, and it's going to be out on Amazon very soon. I also work with children who had COVID and now can't attend school. They have no energy, they have no capacity to think. It's almost like a zombie disease. There was a time where I felt so disconnected, like just going through the motions of my life. So I know from the inside out, it is serious. I now no longer have a family doctor because she's moving to Australia. So I'm literally, like, for the last several months, it's been desperately trying anything I could, even the folk remedies that my sweet friends dropped off, fennel tea in my mailbox. I'm like, I will literally try anything. So I really have a lot of compassion for family doctors not knowing what to do with this. And we have to figure it out. I know people that are now losing their businesses because they're so devastated, like they're so disabled they can no longer work. I'm worried for kids with long COVID. I actually see this beyond a mass disabling event, and I see that we are into a mass extinction event. And I know that sounds dramatic, but for the last 11 months, I'm wondering if I'm going to die. And I know people are dying. So I'm very grateful for this, for being able to talk about this and to be able to share how very serious and how very scary it is. And we really need to do something now. So thank you, David.
Thank you. I think we could all hear the impact of the physical symptoms you described, the terror, the uncertainty, the impact of your ongoing illness on your livelihood. And we can all think about how does that affect all the people in our society who have long COVID or post-COVID illnesses. And also, as I said in introducing her, Dr. Grace is a psychologist. So healthcare providers are not magically protected from getting sick themselves. So Dr. Grace has shared that her practice, she's had to really cut back her hours dramatically, which means that we have a full-time psychologist who has now shifted to part-time. We are seeing family doctors shifting to part-time and pulling back, and nurses having to, they're ill and they're unable to do the hours to the same extent or maybe at all. And so in addition to long COVID affecting patients, it's affecting our healthcare staff and reducing our capacity to care for people.
I think going back to just the terror, one of the most awful things was not being able to breathe at night and then developing very severe insomnia. And I don't know if anyone's had insomnia, but the night voices and the night terrors that can happen, like, it is like nothing I've ever experienced to have night terrors like that. And I'm a psychologist. I know how to have self-compassion, mindfulness, CBT myself to death. It is a systemic biological pathogen that is now in my body that has ravaged my brain, my heart, my lungs, and who knows what other organs. I also have zero appetite. And at one point, I lost the ability to see color. So this is serious. And I'm scared of what my future is going to be. But I'm still stubborn and I'll still advocate. So I'm not done yet.
And sometimes, I've seen different things in the literature where people are going to healthcare providers and being told that they have to reframe their thinking, and it's being treated more as a psychogenic phenomenon. And in fact, there's very recent research published from autopsies and so on showing that there is persistent virus found throughout multiple organs or all organs. I can't remember that exact study. I read it a few days ago, My apologies. I can try to find that citation and send it out to the group later. Danielle, if you can keep track of that for me, that would be awesome. And actually, sorry, in my acknowledgements, I want to acknowledge the CBD team within the Department of Family Medicine, and Danielle Kiss is she provides me administrative support. Okay, so I'm going to share my screen again. Just to check, can you see the screen? Yes. So SARS-CoV-2 is bad. It causes acute illness. We know people end up in the ICU and so on. Lots of people die. We've had more people die in 2022 related to in Canada from acute COVID illness than in 2021 or 2020. What we're talking about today primarily is illness after the acute or immediate infection. So people can have prolonged symptoms or impairment. People can have later development of illness that's similar to the prolonged symptoms. So they might have had no symptoms or have been mild symptoms, but later on develop fatigue, headache, brain fog. Importantly, SARS-CoV-2 infection dramatically increases risk for other illnesses. And there's also evidence of damaged immune responses to other infections. And so increasing the risk of those things. And we're seeing reports of increased zoster, for instance. So study number one, this is based on US Veterans Affairs data. Now, the United States Department of Veterans Affairs provides comprehensive healthcare for its veterans. It's incredible because that's a massive data set, and they have access to the primary care, specialty clinic, and inpatient data for their patients. So this group compared different groups of patients for 821 potential long-term health issues 6 months following COVID infection. And so non-hospitalized people who sought care, so people not hospitalized who were COVID positive or COVID negative and sought care for something else. People who are hospitalized, both with COVID versus people hospitalized with influenza, and then outcomes for ICU admitted patients. And I struggled to find the exact comparison group for that group. So this is their table. I've broken it into two just so that we can see things more clearly. So this is a hazard ratio plot. So for people unfamiliar, the dotted red line is 1, so the standard risk. So this is the comparison group would have this likelihood of something. So for acute coronary disease, so new onset of, say, angina or heart attack, that would be whatever the baseline amount or likelihood, whatever the baseline risk is for a person to have had it, is that dotted red line. And then these other things are for those groups. So for somebody who is hospitalized with COVID versus somebody who was not hospitalized with COVID, they have an over 5 times increased risk of having acute coronary disease 1 year out. So you can see, and then all of these items have error bars. So while this little green dot here is a little bit above the red line, its error bar crosses over. So therefore, it doesn't look like there's not clear proof that for people in the community to have had an increased risk of acute coronary disease compared to people in the community who haven't had COVID, because that error bar crosses. But you'll notice that there's a lot of these things which look kind of like TIE fighters. Their error bars are not crossing. So just look at all these things: arrhythmias, bradycardia, chest pain, and so on. Obesity, diarrhea, fatigue, anxiety, depression, sleep disorder. So many of these things, whenever you see the dot with its error bars clearly to the right of the red line, means that there's an increased risk of those conditions compared to the people without COVID infection. This is massive. You just look at this, is like, whoa, this is a huge amount of increased risk of multiple problems. And these aren't single problems on their own. Like if somebody develops new chest pain, that as family doctors, we're going to do all sorts of tests and maybe get some specialists involved to help figure out somebody's chest pain. If somebody develops new fatigue, those are, again, more tests, potentially different treatments and so on. So it's not that these are like a single event. This is that these are people needing fairly intensive care in the community to figure out what's going on. Now, that Veterans Affairs data does include children. This was the best children long COVID study I could find. They looked at hospitalized patients, both COVID positive and COVID negative, comparing the two groups. They looked at long-term outcomes up to 6 months. They pulled health records, it appears, from the children's hospitals, which might include some specialty clinic follow-ups, but it didn't appear to include records from community pediatricians or community family doctors. And they looked at the frequency of what they call PASC, post-acute sequelae of SARS-CoV symptoms. And so in patients who were COVID positive, they had a 42% risk of those symptoms. And if somebody was COVID negative, they had a 38.2% risk, which is a 3.7% absolute difference if you subtract one versus the other, but it's actually an almost 10% increased relative risk. So children are not immune from long COVID, and this is only a 6-month follow-up. It doesn't though get into like I would think that these are likely minimum numbers, because I didn't see anything in this paper describing any checking with community clinics, family medicine or pediatricians clinics in the community to see, do any of these patients have any of these long-term symptoms. So this is likely an underestimation. Study 3, this is a different study. It was a retrospective matched cohort design, lots of patients, and they were looking at people that either had a COVID-19 clinical diagnosis or a SARS-CoV-2 positive tests. And then they compared against patients seen in the same time period who didn't have either of those two things. And they looked for occurrence of 26 conditions within a year in 2 different age groups. And similar to that first study showed, look at all these circles with their error bars clearly to the right of that baseline rate. And so lots of these conditions coming in at around 1.4 to 1.5 increased risk. Some things such as blood clots in the lung at an over 2 times increased risk. Respiratory symptoms, so that would be like, say, difficulty breathing, chronic cough, coming in at more than 2 times increased risk. And again, those are scenarios and situations where a patient will require a lot of care and investigation and assessment and follow-up and management, and possibly including specialist involvement and other sort of more complex or comprehensive tests to sort things out. Study 4 is back to that same U.S. Veterans Affairs data group. This is looking at reinfection. So the question is, what about if somebody gets multiple infections? Does the risk increase, or do you get that risk of increased, do you get those increased risks of long-term outcomes, either symptoms or other conditions, just with one infection, but it doesn't change anymore with more infections? Or does each infection increase your risk even further? So they compared 3 groups: people who had no SARS-CoV-2 infection, people with a single SARS-CoV-2 infection, and people with 2 or more SARS-CoV-2 infections. And so you can see, first of all, not surprising now, that all 3 groups compared to people, and they actually reported, people with either no infections, so that's the dotted line, people with 1 infection, people with 2 infections, or people with 3 or more infections. And people with any infection, as you can see, are clearly to the right. What's fascinating and concerning is that the more infections you get, you're moving more to the right, so your risk is increasing. So for instance, people with long-term gastrointestinal symptoms, yes, there's an increased risk with 1 infection, it looks to here to be maybe something around like say 1.3, so maybe a 30% increased risk. But with 2 infections, you're looking at over doubled risk. And if somebody's had 3 or more infections, you're looking at 3 times the risk. 3 times. So, and then while immunization does provide protection against serious outcomes from acute illness, and there appears to be some research to suggest that it decreases your risk of long COVID, within themselves, so if people have had, say, 1 vaccination, if you compare people with 1 vaccination with no reinfections, so just 1 infection versus people with 1 vaccination and reinfections, they're still at increased risk. So vaccinations are good, and they don't provide complete protection against the increased risk of long COVID outcomes with additional infections. So their vaccinations are not the single thing we need to do to control this pandemic and reduce and decrease its harm upon humanity. They're a piece of it, absolutely, for sure. I've had 5 shots so far myself, but they're not the only thing. Now, there's lots of data. I'm not going to get into the research on how COVID directly damages immune responses. So it damages our immune system. It injures monocytes directly. And in fact, by doing so, in this paper, it described how one of the mechanisms by the damage leads to the increased blood clotting risk. So by injuring our immune cells, it appears to lead to increased blood clotting risk. Another study showed it inactivated immune cells, and they couldn't find naive T and B cells, reduced mucosal immunity, functional exhaustion of T cells. There are multiple studies, and I'm not an immunologist, and I won't get into the detail. But as the family doc, I'm thinking, whoa, any of my patients who've had COVID once, or particularly people who've had it 2 or more times, they're now at massive, or seem to be at increased risk now of other infections. So it's a pandemic that's generating other immune disease. And it appears to be, that the recent invasive strep infections may be an example of that. So how big is this? So if we know that long COVID is bad, okay, how big is this? So this is getting to think, how many people are at increased risk? So this is pulled from the Alberta Statistics, the COVID-19 database from Alberta Health, and you'll see this is the waves over time, and it looks like things are slowing down. But of course, at this yellow point in time is when the Alberta Health started restricting access to testing. And that was the time when, in fact, they actually asked most people to do home tests. And a question was raised by many at the time. Well, people are doing the rapid tests, but they're not being gathered centrally. How will we know how many people have had COVID? And we don't know. And then since that time, there's been further and further restrictions. So that to this point, my understanding is that the only people who can get a PCR test are when they're a healthcare provider, or when their health provider directly decides to do the PCR test. So we know that a whole bunch of people, the cumulative cases of recorded cases up until the first of this year is nearing 600,000 Albertans. We know it's way more than that, because after this yellow point in time, there was severely restricted access to PCR testing and no central way for Alberta Health to collect the real data on how many people have had or are getting new COVID. Now, there's a seroprevalence in Canada study run by the COVID-19 Immunity Task Force, which does blood work on the population and does statistics to sort of use this to figure out how many people have been infected by COVID. So not immunized or have, so how many people have antibodies that you would only get by being directly infected by COVID? And as of Halloween, it showed that actually there's, in Alberta, there was 73.7% of Albertans have had at least one COVID infection. And that's a stunning number. And that was October. And we know since then we've had another wave and maybe two. It's starting to get complex to keep track of time about all these different waves. So, we're probably up to like 80% minimum of our population having had at least one infection. So to answer the question, how big and bad is this? Well, with a single SARS-CoV infection, risk of all sorts of chronic health issues increased by at least 50%. Each additional infection increases risk beyond that. At least 70% of Canadians have had at least one infection, and lots have had at least two. So this is not, this is just like a modeling what I think is a family doctor. So let's say that the patient care needs from family medicine and what they are relative to pre-COVID. So let's say there was 100 units of family medicine care required by patients in the pre-COVID days. Now, it was obviously probably like 100 million units or something, but let's just say as a base number, 100. Well, when you add in all that long COVID and multiple infections and the reinfections causing increased disease, and these are complex things like difficulty breathing, chest pain, fatigue, depression, that's probably, add all that up, that's probably like an 80% increase. That, because we know that all of these things combine and it's like compounded interest. And so then we know there's a lot of people with delayed care issues. Every family doc I know is seeing patients with more advanced conditions than normal. There are all sorts of delayed care. There's challenging access to specialty care. And so all these things are accumulating in family medicine. And so that's like an increase, maybe like a 20% increase. And that these are, I feel these are conservative numbers. There's population growth. I went to the Alberta statistics and so on. There's recently a big announcement. Yay! In the third quarter of this past year, there was something like a 3% increase in our population. It's like, okay, cool. But with all those extra people, but not really many more healthcare providers, that's an extra volume again of care that's needed. And then there's reduced capacity of the health system to care for people. So that's doctors and nurses who are sick and are or have been going full out and are now burning out. And as we heard from Dr. Grace, or are sick themselves. And so maybe that's a 5% kind of relative increase impact. And so if you add all these things together, and there's other things as well happening in the system, then we're probably looking at somewhere around at least a doubling of care needs. And yet we haven't doubled our number of family doctors, our number of primary care nurses. We haven't doubled the numbers of people in primary care teams. We haven't doubled hospitals, beds and staffing and so on. And we can't do any of those things quickly. We just can't double things. So what do we need to do? We need to do three core things. First, we need to stop and slow more SARS-CoV-2 infections. Second, we need to change the way we work. And third, we need to research and train about long COVID. So we're currently in our 8th wave. And Dr. Gasparowicz, and Dr. Diego Bassani put together this idea that we're not in endemicity. It's not the same infection that's sort of circulating. No, what we're seeing it's a piling of epidemics, one upon the other, and they're getting closer and closer, and they appear to be getting bigger and bigger as we're getting more and more immune evasive variants, and as people are have abandoned many measures of stopping transmission, and there's been slow uptake on boosting and so on. And XBB 1.5 is coming, but actually, like, I started putting this presentation together, but now it's here. We know it's here. So in the very limited testing that we do now, there is already this XBB 1.5 is here in Alberta right now. And it appears to be highly immune invasive and highly contagious. So we've got a ninth wave about to break upon us. SARS-CoV-2 is airborne. This is not a new discovery. In 1974, Dr. Monta published an article demonstrating that it was likely that coronaviruses were airborne, and used mechanistic models showing that there's the only way to explain some of these kinds of transmissions were that it was airborne. But to be sure, Dr. Greenhall and her team pulled together the evidence demonstrating that SARS-CoV-2 is airborne in May 1st, 2021. And there's been multiple studies since showing this. We don't need any more studies to prove that SARS-CoV-2 is airborne. Once we know and recognize SARS-CoV-2 is airborne, then we need to do a fundamental thing. Medicine, physicians, we need to make way for engineering and air science. Because airborne pathogens are the domain, the ways to mitigate airborne pathogens is through air science engineering. And they're the ones who know how to do this. It's like, you know, we haven't done randomized control trials on parachutes or seatbelts. No, if it's mechanistically known how we can stop these things, then that's what we need to do. And we need to, as a discipline, be humble and recognize that management of airborne pathogens, when there's a massive field of airborne science, we need to make way. And, you know, as family docs, it's my job to recognize my limits, and that's when I will pull in a consultant specialist into the care of my patients. But we as a discipline need to do that and say, we are at the end of our competence. We need the airborne science people to guide us and make decisions over how to stop this airborne pathogen that is big and bad. So, but some of the things that I've learned from them are, first of all, masking, N95 or better, and masking for all. Masking for all in any indoor spaces. Massively improving ventilation and monitoring air quality for ventilation. Filtering the air through Corsi Rosenthal boxes, HEPA filters, and other things. Far UVC is emerging as potentially a great way to sterilize the air. These sorts of things, though, must be society-wide. Individual efforts are insufficient and burdensome and frankly discriminatory. So if somebody like myself had increased risk of poor COVID outcomes, if I'm having to bring in HEPA filters into all of my places of work and I'm masking and so on, that first of all, one person masking we know only provides partial protection. So when everybody is masking, it keeps their air in, keeps their potentially infected particles, their airborne particles. It reduces the ability of those particles to leave the mask. Putting all that on an individual is challenging, particularly for people with disabilities and chronic medical conditions. And it's just, as we can see from what's happening, it's insufficient. We need these to be society-wide, and it worked. Our first wave, there were predictions that were based upon good data to say that we would have been overwhelmed in the first wave and shortly after. And instead, by doing different mitigations, we actually did wrestle things to the ground. Now, it's not easy, some of this stuff, but we don't really have a choice. We need to open testing wide again and get back to test, trace, isolate, because it worked. We know it worked. We need paid sick leave so that anybody who has symptoms or is positive is able to isolate. And we need massive vaccination campaigns. I've seen the vaccination campaigns for influenza. I'm not seeing any vaccination campaigns for COVID. So this is what could happen if we decide to actually target transmission and work on these things. We can spread out these waves, and that they would be a lower hit, a lower burden to people in our community, and therefore we would have less long COVID. So, but the next thing we need to do is change the way we work. We need to maximize the doctoring time so that family doctors are we're doing most of the time we're spending with patients and in patient care is stuff that we are required for. We need everybody to be working at full scope, not just family doctors. We need everybody to be working at full scope. And I think we need to, at this point, knowing the tsunami of chronic disease that is unfolding in our patients, we probably need a massive change in medicine where we move most primary preventive care to nursing, within care teams and patient-centered medical home model, although there are shortages in nursing as well. Because simply, we need physicians to be focused on helping patients figure out their difficulty breathing, their fatigue, and their depression. And I love doing primary prevention and primary preventive care. And others can do that really well as well. We need additional hands on deck. When you see your dentists, the dentist is spending most of their time on dentist work, talking to the patients, doing procedures, doing assessments, and so on. They have dental assistants working very seamlessly with them, doing, setting up forms and generating, prescriptions or whatever. I was in an ortho clinic for quite a number of visits, and, I received great care, and it was fascinating. There was this ortho clinic assistant by the side of the orthopedic surgeon, so that it made the orthopedic surgeon more efficient, working as a scribe, filling things out, and so on, so that that surgeon in this AHS facility could see more volume of patients, because people need that care. So we need that same approach to primary care. Now, we need a hard reorientation of our whole health system to primary care and patient-centered medical home. We have to end this system that we have where there's so many things that are unfriendly to primary care. This will require resources. It'll require system audits and changes. We need changes in communications. There's many great things about the new electronic health record and AHS facilities here in Calgary. One of the interesting things was that it has doubled the numbers of results and reports and so on that come to a family medicine office. And it's fascinating that a health system was able to be designed and accepted that not only increased the work to family doctors, that the technical form work. And we now need to ensure that, no, we are maximizing the efficiency of our family docs because our patients need it. Because if family docs and family practice teams are unable to keep up with the care needs of patients, then that's going to jam up our specialty consult referral pathways, which they're already jammed now, but they'll get more jammed. So this would actually be a cultural change. So the days of sending in a referral and 3 months later getting back a rejection that is turning down because there's one piece of information missing, and then being told you'll have to redo everything all over again. No, we need a cultural change where everybody in our health system feels that they are responsible to help the health system and particularly primary care succeed. Because if not, specialty care will fail as well. And ultimately, it's our patients who will be injured and see disease and disability, delayed diagnosis, delayed access to care, which is going to have a massive impact on our health system sustainability and our sustainability of our economy. And finally, the third pillar is we need research. We need research into treatments, and there's some ongoing. We need a massive war footing research into long COVID and post-COVID conditions, and what are the barriers patients face? Are there ways to do secondary prevention to prevent those post-COVID conditions? research into the system design and innovations needed. Our medical education system must pivot to recognize the massive health injury caused by SARS-CoV-2. We need training of health professionals and the right kind of research for different questions. And we need to disrupt this hierarchy of randomized controlled trials over mechanistic research and reframe things that there are times when a randomized controlled trial is the right kind of study to do. And there are times when mechanistic research is actually superior. And this is one of them. SARS-CoV-2 can develop mutations that can enable it to evade immunizations, but it can't get past, or it's very hard to get past, good masks. And a virus can't mutate out of an airborne status to somehow get past an N95 easily. If they get smaller, they're actually trapped more. If they get bigger, they're trapped more. And even at the static electricity and so on that's in it traps a tremendous amount. SARS-CoV-2 virus can't immune escape good ventilation. And finally, health providers and physicians, we need to train them in change management. So how to recognize when they need to change and how to be open to new data. And then also how to actually bring change in their healthcare teams and healthcare spaces where they work. And so here are the three things we need to do. And the key thing is, we don't have a choice. We do not have a choice. If we continue on the same path we're on, we're talking about more and more people with chronic disabilities, more and more people with complex conditions, probably a tripling of the healthcare needs of our population over where it was pre-COVID. And we just can't catch up unless we change. So we have to stop the fire and change the way we work and figure things out better. And we have no choice because it will only get worse. Now, here are some people, if you're thinking about who to follow on Twitter for good insights and analysis, here are some great people. There are more, and my apologies if I follow people in different threads and so on, and and it's not that I'm caught in Twitter circles of reinforcing each other. No, it's like I'm looking at links and observations and insight and debate, and these are good people to consider following if you want to be more plugged in to good, thoughtful SARS-CoV-2 and long COVID insights and analysis.